Engaging in Aging, JDC-Israel's international podcast. JDC is the largest social research and development incubator in Israel, promoting the development and implementation of hundreds of solutions for social-economic change nationwide. In this podcast, we will focus on the various challenges of aging, including our response to the COVID-19 pandemic.
Hello, and thank you for joining our podcast today. We will be talking about palliative care and end-of-life situations. My name is Naomi Keren, and I am the Director of Knowledge Development and Learning at JDC-Israel. In today's talk, we will present a complicated and sensitive subject. Joining me is Irit Fischer, the Director of Services in the Community in JDC-Israel and the Head of the National Program of Palliative Care, which is led by the Ministry of Health. Irit is a social worker and has a degree in law. She is an expert in the field of gerontology. We often deal with how we want to live, or quality of life, and our future planning. To what extent do we think and deal with our death? How would we like to end our life? What treatment we would like to receive? Who would we want to have around us? Irit, what are the reasons people avoid talking about it?
Nobody wants to think he's going to die. It's against our natural desire to live. We are afraid to think about it, to talk about it, and we are afraid to plan our death.
Okay, I can understand it. But why do professionals avoid talking about it?
From the same reason, but especially because they are not taught to talk about it. When they study the studies, they learn how to make people live better and longer, and they are not taught not to think about it, not to talk about it, and not to treat people when they are going to die. Most of the professionals see in death failure. So it's very natural that they won't talk about it.
Why should you talk to healthy people about death?
When you talk about it, it's in the open. And if it's in the open, you can think about it, you can plan, you can talk with your relatives about it, you can tell your relatives who is important for you, how are they important for you. You can think how you want to plan the end of your life. How would you like to be treated? Would you like to be treated in a hospital? Or maybe you would like to stay in your home? Would you like to prolong your life? Or would you like to end your life when it's possible and you can still say goodbye and depart from your family?
So we're really getting the ability to choose when we talk about it, when we are healthy.
You can choose, but of course it's not to choose everything because we are still in some kind of way of living and many of the patients are afraid to choose. But still it's a possibility to talk about it and to have some autonomy and to decide. And it gives the patients, many times it gives them strength to fight.
In this podcast, we will discuss a matter relevant to any person, and yet most of us have no knowledge about it and have hardly heard of it. Palliative care. What does it actually mean?
Palliative care is a way of treating and caring, medical but not only medical. It's given to anyone who has chronic life-threatening disease, and everyone can get it and should get it when he is diagnosed with a life-threatening disease. The classical example that we all know is cancer. But as we know today, also heart failure, kidney failure, Alzheimer's disease, and so on are threatening disease. So everyone actually who is diagnosed with a disease like this can get and should get a palliative care. Palliative care is a way of life, and it's a way of thinking how should end of life be and what treatment the sick people will get. We have to understand that for palliative care, dying is part of life. And if you can choose and if you can plan how you will die, we think and we believe that life will be much better all over the life and not only in the end of life.
So palliative care is a way of treating and caring. So what is actually the difference between medical care and palliative care?
I think the main principle leading the treatment is providing choices. So the sick one, or even if he's not sick yet, he can choose how he would like to end his life. He would like to end his life in a hospital or at home. He would like to prolong the treatment, or if he knows that the treatment won't help, maybe he can decide the last days, the last weeks, even the last months, to be with his family, to go around the world, to make things he loves with them. I think one of the most important things is that it gives the patient and his family the ability to be together in the open and to talk about what's going to happen. Palliative care believes that we have to give everyone the opportunity to talk about what he wants, about his choices.
Mm-hmm. And also to do a closure. It's also an opportunity to do some closure.
Exactly.
Mm-hmm. The issue you're talking about are not simple. In an instant, we delved into a time in our life that no one of us wants to talk about or think about it, and we hide or ignore death.
You are absolutely right. Even doctors and nurses find it difficult to talk about end of life directly, and they try to talk about it from other ways. Think about it. How many physicians are free to talk about it? In our national program, when we started it, we sent one of our colleagues to her physician, and she asked him if she can talk with him about end of life and how she would like to end her life and to put some directive. And he said, "You are young, we don't have to talk about it, it's too early. But if we want to talk and we want to say what we would like that will be in the end, I think it makes life much better and much easier. And it also puts it in the open with the family members. And you can say everyone not only what you would like to have in the end, but also what is important for you in life, not only
It's interesting how it's influence our regular life also when we are healthy and not only for our end of life time.
Exactly.
Can you please explain to us what is done during the palliative care?
Yes, of course. Palliative care is, as I said before, a multidisciplinary team that is specialized in palliation. The team includes, as I said, a physician, a nurse, a social worker, a physiotherapist, an occupational therapist, a dietitian. Every one of them has a place in the team, and the most important thing is that they work as a team. The team consults among themselves how to proceed and is available for consultation for the patient for 24/7. But most important, they look at the person and his family as a whole, and not only the patient. As for your question, what is done to the patient and the family, I think there are two main parallel motions. The first one is providing maximum physical comfort and minimum suffering. Many times people are not afraid of dying, but they are afraid of the suffering that will be before they're dying. So it's very important for the palliative care to treat symptoms as nauseousness, as shortness of breath, and of course, avoiding pain. It makes the end of life much easier for the patient and his family. And the second one is that the palliative team uses the alleviation of the symptoms, and it allows the person to free himself from dealing with all the suffering that might happen.
So it is living our last days or months in comfort and without suffering. Wow. I hear you, and I think to myself, people must hear it. They need to be much more knowledgeable about the options of palliative care. Eventually, it is our life and our loved ones' lives. I also question the medical system. How come palliative care, both practically and the way we approach patient, and is not implemented in each and every hospital or in clinics that take care of people in this situation?
Yes, you are right. We are constantly thinking how to spread the news and convey our message. In Israel, and not only in Israel, in about 10 countries around the world, there is a national program for palliative care. And this national program plans how to make palliative care better well-known, not only to the staff, to the medical staff, but also to everyone. Because even if the medical staff knows how to treat, many of the people, they don't know that it exists. And if they don't know that it exists, they don't know to ask for it. So we work very hard in all those countries that has the national program, and other countries, of course, to implement palliative care. But most of all, it's not only the medical approach, the palliative medical approach, but mostly the understanding that it's possible to treat in another way and not only the medical and the curing way. Because if you decide that cure is the main reason that you treat people and not the main reason is to make them better, not to suffer, in the end of their life, it's a very big difference. We have developed in Israel courses that teach professionals that are not specialized in palliative care, but are, again, physicians, nurses, social workers, and so on. And we teach in those courses how, first of all, what is palliative care? How can they refer to palliative teams, and what is possible for them to give, even if they are not specialized in palliative care? First of all, the possibility to talk with the patient about palliative care, about the end of life. You know, it's very strange. You think that when somebody studies in medical school or nursing, they learn how to be in the side of the patient when it's the end of his life. But they don't know how to do it, and they don't know how to talk about it. So first of all, we try to teach them how to talk about it, how to think about it, to be open about it. It's very strange, but most of the medical staff, they don't think about their death, and they don't think about the relative death. So first of all, we have to give them the opportunity to think about it, and then they have to learn how to treat patients that are in the end of life. We have also about 300, we call them champions, from every organization in the medical field in Israel. They have a team of multidisciplinary workers, and they came to us and they had a program of almost 2 years, how to make the change in the organization so the organization will talk palliative care and not only medical treatment.
I see you do a lot of different training to medical staff. We live in troubled times, a worldwide pandemic that threatens mostly the lives of the elderly. Does a preparation for end-of-life situation have a special meaning during the corona crisis?
Of course. During the corona, we realized how important it is to prepare the patient to departure and to dying. And we see in the corona pandemic that many of the patients couldn't say goodbye to their families, and the families couldn't depart from them. We have one of the nurses that is part of a team in a very big hospital, and she is a specialist in palliative care, and she told me only a few days ago that one of the most difficult things for her as a nurse, as a professional, is to be next to a dying patient without the possibility to touch him, with the mask and everything on her, and without being able to bring the family to depart from him. And she says it's a big suffer for everyone. It's a big suffer for the patient, it's a big suffer for the family, and it's a very, very difficult for the team itself. So the pandemic brings us a lot of difficulties that we didn't know before, and we still learn how to treat them. We know that it's very frustrating for the teams. We talk a lot about compassion fatigue, which is a part of the teams today. They are dealing with a lot of death, and it's not easy. And we still have to see how we treat them for a longer time.
What more does Eshel do to promote a palliative agenda?
We believe the changes starts with the mindset of the medical teams. And here rests a major difficulty springing for the fear to talk to patients about end-of-life issues. So we decided in Eshel to develop a digital toolbox that includes simulation, videos, and transcripts designed to encourage physicians and nurses to openly talk to patients about this very sensitive subject. The conversation can take place in various stages. The first one, when a person is healthy and can prepare in advance to the future. The family physician in the community will call the patient and invite him to a conversation about the available options. The second one is when a person is diagnosed with a life-threatening illness and the physician already meets him in circumstances when he is getting acquainted with his new condition. And the third one is when a person is hospitalized and when his condition is already very bad, and then the physician can talk with him about his last days or weeks.
Mm-hmm.
And I would like to add that it's also possible to do at least part of the talks through the phone or a video chat, and it's important in these days.
Right. How do you see the field evolving? What is your vision for the healthcare system in the next 10 years?
The national program vision is that the health system will talk palliation. I mean, everyone will be able to say what he prefers, and all the medical staff will know how to listen and how to make those conversations. And most of all, everyone in the medical field will know how to treat the patient so they won't suffer, and to give them the opportunity to depart from the families with dignity and according to their choices.
Mm-hmm. Thank you very much, Irit. It was very interesting talk, and the subject is so important. I believe we must act and raise awareness in the general population so people will be aware of their rights, that they can choose how they want to die and what kind of treatment they want to get. I also think you need to expose the medical and the paramedical profession in this vital knowledge.
Thank you for joining us for this episode of Engaging in Aging. We hope to see you in our next episodes. For more information about what we spoke today and more, please see our bio below or visit our website, eshelnet.org.il.